Outlook to 2016, What the Coming Years Mean for Healthcare webinar. I'm Danielle Capilla from Wolters Kluwer. Before we begin today's webinar and introduce our featured speakers, I want to cover a few quick housekeeping items. First, questions and answers. We ask that you use the Q&A menu bar located in the GoToWebinar menu on the right side of your screen to submit questions, and all lines have been placed on mute. As far as handouts go, to download a copy of today's presentation, you will need to use the URL that was sent out in the reminder email this morning or use the link posted in the GoToWebinar chat box. CEUs. Today's webinar has been approved for CEUs from HCCA, and an email with a survey and download instructions will be sent within 24 to 48 hours of the webinar. And now I would like to introduce Keith Fontenot, Managing Director of Government Relations and Public Policy at Hooper Lundy & Bookman, Marty Corey, the Chair of Government Relations and Public Policy at Hooper Lundy & Bookman, and Katrina Pagonis, Senior Counsel, also at Hooper Lundy & Bookman. And now I'm going to go ahead and hand today's presentation over to Marty Corey.
Thank you. Good morning or afternoon, depending on which time zone you're in. Thank you for joining us today. We will be discussing our view at this point of the outlook for next year in the Congress and beyond the Congress, also with the courts and the executive branch. The good news, I think, to start off is that Congress completed its work during the lame duck session, and as of last night, the Senate wrapped up its business and went home. Before doing so, they did finally manage to squeak out one more bill, a tax extenders bill that was needed for 2014. As the chairman of the Finance Committee noted, with 2 weeks left to spare, they managed to do tax extenders. They'll have to come back to that next year. But on the health care front, the Cromnibus, as it's known, otherwise the Omnibus Bill, which was the subject of a good bit of contentiousness over the course of the last few weeks, was adopted. The President will sign it this week, and it will then take effect. The key thing, probably beyond any of the specifics in that omnibus or cromnibus, as it's been called, is that it got done at all. The congressional leadership worked very hard. They had a good bit of divisiveness within each of their conferences, both Democrats and Republicans. And so just the fact that they were able to accomplish it and clear the decks is something that they will continue to, I think, benefit from as they go into next year. So with that in mind, let me turn it over to Keith to talk a little bit further about that omnibus bill.
Hi, yes. Possibly a worse title one cannot really imagine, the Cromnibus. We joked around here, it sounded like a mythological Greek monster. It's a $1.1 trillion bill that combines 12 of 13 regular appropriation bills in their entirety, along with a continuing resolution for Homeland Security. And that really reflected the congressional desire to keep issues open around immigration. It reflects really an extraordinary commitment on the part of the appropriations committees to getting their bills done, and to the leadership in many ways in terms of working out the issues and ensuring they can legislate. One important thing to remember is this year is a little bit easier because it is the last year of a Ryan Murray budget accord, which kind of smoothed the path for a lot of this. Starting next year, I think things will get more difficult in the appropriations front, particularly as the defense pressures grow and in terms of the level of the caps and the cuts on that side. And you will see, I think, increasingly scarce dollars on the domestic side. The bill did include $5.5 billion, more or less, $5.4 billion for Ebola and $5.6 for ISIL on the defense side as emergency funding. That lets them do it outside of the regular caps. On the Ebola side, about 2.5 went to HHS and about 2 went to AID for activities overseas. And, you know, that was a modestly less than what the President asked for, but not really significant. There was a lot of noise. You'll see a lot of people pick up a lot of the staff notes on what the bill does, and you have to really distinguish between what's reported in terms of description on the bills and then what's in the bill itself. So, for example, we made a lot of some requests for information on home health. These are very common things that the Appropriations Committee do. They ask for information on all kinds of things. It's not a statutory limit or anything. It may or may not signal where they want to go in the future, but it basically is a normal part of the process. There were some interesting actual changes. One of them, which you've heard a lot about in the press, around risk corridors and CMS funding related to the Affordable Care Act. The interesting thing about that is it seems to be something that will let the administration continue to run and implement those programs more or less as they had spelled out in regulation. They did impose some limits, but it doesn't appear to be anything that really shuts the program down at all. So that's really kind of a remarkable thing, given that they didn't get a whole lot done this year. Overall, pulling out the $1 trillion appropriation bill was a pretty big deal, and it really is a major thing for next year, because otherwise this would have been the first thing out of the blocks in the new Congress. So this was a major clearing of the decks. With that, slide 4.
So Alan, let's just talk briefly about the lineup in the next Congress in terms of the committees of jurisdiction over health care. In the House Ways and Means Committee, which has jurisdiction over Medicare, as well as obviously tax policy, pension policy, trade policy, has a new chairman, Paul Ryan, not new to the national stage. Congressman Ryan of Wisconsin was previously the House Budget Chairman and has already made his mark on health care over the course of the last few years. The ranking member continues to be Congressman Sandy Levin of Michigan. In the House Energy and Commerce Committee, the chairman remains the same, Fred Upton of Michigan, but with a new ranking member, Frank Pallone of New Jersey. I think the interesting thing in this past Congress on the Energy and Commerce Committee's agenda was that they produced a good bit of bipartisan legislation, most of it around pharmaceuticals, FDA, and issues of that nature. But they were very workmanlike, got a lot of work done. Some of those bills didn't make it through the Senate, but that could change in this next Congress with Republicans now in control of the Senate in the next Congress. Over to the Senate. The Senate Finance Committee obviously has a new chairman with Republicans now in control, Orrin Hatch of Utah. Senator Hatch is no stranger to the chairman's gavel. He's been a chairman previously in other Congresses. The ranking member becomes Ron Wyden, who has been chairman for the past year. Senator Hatch and Senator Wyden both have in their history a lot of bipartisan activities, a lot of bipartisan legislation, efforts to try to work together would be expected from the two of them. The question will be how much latitude they will have even as chairman and ranking member of the Finance Committee. The Senate Health Committee, Health, Education, Labor, and Pensions, has a new chairman, Senator Lamar Alexander, and a new ranking member, Senator Patty Murray. Senator Murray was in this past Congress chairman of the Senate Budget Committee, has a very strong reputation also for accomplishing bipartisan legislation when it's possible, as we saw a couple years ago with the Ryan Murray budget framework. Still out and not yet decided issue is what happens with the Senate Budget Committee. There we still have up in the air who the new chairman will be, either Mike Enzi or Jeff Sessions. Senator Sessions has been the ranking member of the Budget Committee in the past Congress, but he is outranked in terms of seniority by Senator Enzi, who has said that he wants to be chairman, and that matter is still open and will have to be resolved early in the next Congress. Now, you might say, well, does that matter? It matters a lot because, as Keith will discuss later, if we are looking at a budget resolution that will be conferenced by both houses and a reconciliation bill which might be embedded in that budget resolution, who the chairman of the Budget Committee is matters. And then finally, the ranking member on the Budget Committee is Senator Bernie Sanders, an independent who caucuses with Senate Democrats. Senator Sanders is a very outspoken member, but earned good marks as chairman of the Veterans Affairs Committee in the past Congress dealing with all the issues at the VA. So with that, we're now going to shift our attention to where we think there may actually be even more of a spotlight in the next year than the Congress, if that's possible, and that is with the courts. Katrina?
Thank you, Marty. Yeah, so looking ahead to 2015, we expect that the judiciary branch is poised to play a pivotal role in healthcare reform. That's because the Supreme Court has granted cert to hear a challenge to the ACA exchange subsidy. The Affordable Care Act included subsidies to offset the cost of premiums for individuals that enroll in coverage through an exchange and have income that qualifies, namely income between 100% and 400% of the federal poverty level. Most people that enroll through the exchanges are eligible for these subsidies and receive these subsidies. The tax credit is given on an advance basis, so they get a monthly credit towards their tax credit that's paid directly to the insurance company, decreasing the monthly premiums owed by the insured and making insurance more affordable than it would otherwise be on the normal individual marketplace. The Supreme Court challenge involves the question of Chevron deference and statutory interpretation. The IRS interpreted the ACA to allow for these subsidies to be available nationwide as long as an individual enrolls in an exchange, whether that exchange is a state-based exchange like the exchanges set up in Washington, California, Minnesota, Kentucky, and New York, or a federally facilitated exchange like those set up in Texas, Florida, Virginia, Pennsylvania, and so forth. The challengers contend that that's not a permissible interpretation of the ACA and therefore should not be accorded any deference under Chevron. And of course the administration is defending it under the Chevron analysis. The oral arguments, we expect those to occur this spring by the end of April, and a decision will be issued by the end of June, most likely at the tail end of June. So the timing will have a similar feel to it as from what we recall back in 2012 when we had NFIB versus Sebelius concerning the individual mandate and the Medicaid expansion. As I mentioned, the question presented by the challengers is whether the IRS can permissibly promulgate regulations that extend these tax credit subsidies to coverage purchased through exchanges established by the federal government under Section 1321 of the ACA, when the ACA specifies that the tax credit subsidies are available for coverage purchased through an exchange established by the state under Section 1311. We're going to talk about the merits of the case and what's at stake in a moment, but first I want to briefly discuss the significance of the Supreme Court's grant of certiorari. So under the Supreme Court's long-standing practice, 4 or more justices are required to grant cert. We don't know if it was a 4-5 vote or if there were a greater number of justices that were inclined to hear the case. We also don't know what side of the aisle those justices wishing to hear the case were sitting. There's been a lot of speculation that it might have been the conservative bloc of the Supreme Court that chose to hear the case. But there's also some that have theorized that the more liberal-leaning bloc of the Supreme Court may have granted cert in order to get greater certainty and security by, reaching a final determination of this question, rather than leaving the ACA exchange subsidies in a kind of legal purgatory. Under the Supreme Court rules, certiorari is a matter of judicial discretion, and it's only granted for compelling reasons. And these compelling reasons might include a circuit split, misconduct, or conduct that calls for an exercise of the Supreme Court's supervisory powers. That, of course, would not be at issue here. Or an important question of federal law that has not been but should be settled by the Supreme Court. Now, there are a number of challenges to the ACA exchange subsidies pending in the courts, and King versus Burwell, the one that the Supreme Court granted cert on, is just one of these. It arises out of the Fourth Circuit. The Fourth Circuit concluded that the IRS rule should be granted deference under Chevron and was an appropriate exercise of executive authority. Meanwhile, we have a decision in the D.C. Circuit, a panel decision. This is in Halbig versus Burwell. The D.C. Circuit panel decision and the Fourth Circuit panel decisions were actually both issued on the same day in July, which is fairly unusual. But the D.C. Circuit decision hasn't hit a final resolution because the D.C. Circuit sitting in bank has decided to rehear the case. So that means the court as an entirety is authorized now to hear the case rather than deferring to the three-judge panel's determination. So the conflicting decisions between the D.C. Circuit panel and the Fourth Circuit panel actually do not create a circuit split yet. We don't have a circuit split and wouldn't have had a circuit split until the D.C. Circuit reached a final decision sitting in bank. We also have a pending case in the 10th Circuit, Oklahoma ex rel Pruitt versus Burwell. There, the district court has vacated the IRS rule, and the matter is on appeal to the 10th Circuit. Both the 10th Circuit and D.C. Circuit proceedings have been stayed pending the Supreme Court decision in King. And Indiana versus IRS is the least developed of these cases, and their cross motions for summary judgment have been filed in the district court. There's also another ACA exchange subsidies challenge that has recently been filed, and this is of a somewhat different flavor. Alongside the premium assistance tax credits that are the subject of King versus Burwell and these other three cases, the Affordable Care Act also provides for cost-sharing reduction subsidies. These help eligible individuals between 100 and 250% of the federal poverty level offset cost-sharing obligations so that their deductibles, co-payments, and out-of-pocket limits are lower on exchange plans than they otherwise would be. We'll talk further about this case in a couple of minutes, but the United States House of Representatives filed a complaint in the D.C. District Court on November 21st, 2014, shortly after the President made his announcement concerning immigration. So that case is just at its inception, but we should expect perhaps some developments over the coming year. So focusing on the premium tax credit challenges and King versus Burwell, when we think about why the Supreme Court granted cert, there's no circuit split, and so that remains the remaining justification or compelling reason for granting cert would be an important question of federal law that has not been but should be settled by the Supreme Court. As I mentioned before, this is a Chevron case, and we have a number of justices on the Supreme Court who largely focus on administrative law and are deeply vested in this court's Chevron jurisprudence. These are Justice Scalia, Justice Breyer, and Justice Kagan. Justice Scalia was actually a professor of administrative law before he was elevated to the bench, and Justice Kagan, she doesn't have much of a paper trail before becoming a justice, but this was one area of scholarship for her in which we do have a paper trail. And these three justices have differing views on the margins of Chevron. but regarding questions like, for example, what is required in order for an agency interpretation to even be analyzed under Chevron? They have very different approaches to that kind of question. But this case actually does not raise very interesting questions under Chevron. The IRS rule is contained in a final regulation that was subject to notice and comment rulemaking. And so there's no question about its authority in terms of an agency interpretation or the applicability of Chevron. Rather, this case is largely going to turn on questions of statutory interpretation. How should the ACA be read to understand whether or not Congress has spoken on the issue and whether the IRS's interpretation is reasonable? Now, Justice Scalia, of course, has written extensively on his models for or approaches to statutory interpretation. And one would expect that when we see briefing in this case, there will be at least a significant amount that quotes directly from Justice Scalia's prior works on statutory interpretation. There are some things in his writing that actually would greatly favor the administration's case, and it will be, while people suspect that the conservative bloc is largely looking to overturn the IRS's rule, it will be interesting to see how the justices' approach dovetails with their larger approaches to statutory interpretation. In main part, Justice Scalia has been very explicit that you have to look at the context of a provision in a statute in order to understand how that statutory provision or those individual words impact the larger statute and what kinds of meaning one should assign to those individual words. And that brings us to the merits of the dispute. As I said initially, the ACA specifies that the premium assistance tax credits are available when an individual meets the income threshold and so forth, and enrolls in coverage on an exchange established by the state under Section 1311. The challengers of the IRS rule focus on this language and argue that it should be given its plain and literal reading, and under that plain and literal reading, the provision should restrict these subsidies to state-run exchanges exclusively. On the flip side, the administration has a number of arguments as to why this should not be given the weight it's given by the challengers. First, the location of this language is somewhat odd. It's actually found in the provision explaining how the premium assistance tax credits are to be calculated. There are separate provisions of Section 36B of the Internal Revenue Code that discuss eligibility for the exchange and so forth. And this restriction is not found in those provisions. Instead, it's in a math provision, a provision concerning the calculation of the amount. And one of the common rules of statutory interpretation is that Congress does not hide elephants in mouse holes. And one would, and this would be an instance of putting a very significant restriction on the availability of subsidies in a strange place. And so that at least suggests that Congress may not have intended the meaning being assigned by the challengers to this provision. And the administration, in presenting an alternative construction of this provision, argues that Sections 1311 and 1321 of the Affordable Care Act establish equivalency between state-run and federally facilitated exchanges. So the literal language of established by the state under Section 1311, when read in light of the ACA as a whole, particularly this equivalency provision at Section 1321, actually means any of these public exchanges, whether it's established by the state, established by the Department of Health and Human Services under Section 1321, or established by the state and HHS in partnership with one another. This argument about the equivalency of the exchanges actually pulls from some other provisions of the ACA as well, or is potentially supported by other provisions of the ACA. First, the term exchange is defined as an American health benefit exchange established under Section 1311 of the ACA. So this language established by a state under Section 1311 or established under Section 1311 is used frequently in the or not infrequently in the ACA, and the ACA would largely not make sense if that reference to Section 1311 was meant to exclude Section 1321 established exchanges, because the federally facilitated exchanges would fall outside the definition of an exchange and would actually have very little operative authority. We're moving along to Section 1311. It uses that term, American Health Benefit Exchange, referring it to as an exchange within that title. And Section 1321 says where the state fails to establish an exchange in time, the Secretary of HHS shall establish and operate such exchange within the state. And that word such exchange is, the administration argues, references back to an American Health Benefit Exchange, which is an exchange established under Section 1311, establishing the equivalency between these two types of exchanges. The administration will also likely point to a couple of other provisions of the ACA. In the premium tax credit provision, Section 36B of the Internal Revenue Code, there's exchange reporting requirements that include a requirement that all exchanges, including federally run exchanges, report to the IRS regarding data on advance payments of premium tax credits. And the administration argues that that provision is redundant or makes little sense if the federally facilitated exchanges are not in fact authorized to give advance payments of premium tax credits. In addition, Section 1312 of the ACA, which defines qualified individuals, meaning those individuals that are eligible to enroll through an exchange in individual coverage, it uses a definition that again turns back to an exchange established by the state. So a qualified individual must reside in the state that established the exchange. And only qualified individuals purchase qualified health plans on an exchange. So the administration will likely contend that Section 1312 again makes clear that there is this equivalency. Otherwise, no one would be eligible to enroll in coverage through a federally facilitated exchange, and the federally facilitated exchange would be redundant or superfluous and futile, which it's unlikely that Congress intended to create federally facilitated exchanges that couldn't actually offer products to potential enrollees. So in terms of what's at stake here, subsidies are something that have made premiums on exchange plans affordable for millions more than would otherwise be able to afford coverage. In 2014, we had about 8 million individuals that selected exchange plans. And when all is said and done, the final numbers in terms of who was eligible for subsidies actually exceeded 85%. It varies somewhat between state to state, but it was in most instances between 85 and 88% of individuals. So these are the vast majority of exchange enrollees tap into these subsidies in order to help them pay for their premiums. And these enrollments that we saw in 2014 only represent a little more than a quarter of eligible individuals. So once everything is fully rolled out and we have full uptake of the exchanges, the Congressional Budget Office estimates that we're talking on the order of 22 million enrollees in 2016 or 2017. HHS is a little more modest with its numbers, but when we talk about a full rollout, we should be expecting 20 million plus. And only 16 states operate state-based exchanges. So if the challenge succeeds and the Supreme Court overturns the Fourth Circuit, most of the individuals that enroll in coverage through the exchanges in most of the country are going to see significant price increases. If they're enrolling in a federally facilitated exchange or a partnership exchange, they'll no longer be able to tap into these subsidies to help them pay their monthly premiums. And that it would, not just increase in that year, their monthly premium amount that they pay out of pocket. In subsequent years, it would likely drive healthier individuals out of the marketplace and retain less healthy individuals due to adverse selection in the marketplace, driving premiums up. So not only would the cost of premiums be higher because of the lack of subsidies, they would also be higher because of the adverse selection that would result from that price increase. As I mentioned, 16 states run state-run exchanges. But when we look nationwide, we actually see a number of flavors of exchanges. The majority of the country has exchanges established by the Department of Health and Human Services under Section 1321. And these are some of the major population centers, including Texas and Florida. But we also have and these are the dark red states on the map. The brighter red states are ones that have federally facilitated exchanges for the individual market, but have established a state-based exchange for the small group coverage. So that's Utah and Mississippi. If they retain their federally facilitated individual exchange, they would be impacted in the same way as Texas and Florida. We also have partnership exchanges. These are in Illinois, Iowa, Arkansas, Delaware, West Virginia, and New Hampshire. And in these partnership exchanges, HHS takes the laboring oar in establishing the exchange. It's operated on healthcare.gov, but certain functions are delegated to the state. In part, the state can choose which roles it wants to take. These might include consumer assistant role, a consumer assistance role, or a role in health plan management. Now, the D.C. Circuit decision involving Halbig versus Burwell, which is on hold for now, actually arises out of West Virginia, which is a partnership exchange. Interestingly, there's very little discussion in the D.C. Circuit panel decision about what it means that West Virginia operates a partnership exchange in which the state has plan management functions. So that's one flavor, one step removed from a pure federally facilitated exchange. We don't have a lot of clear jurisprudence on whether that would constitute a state-run exchange other than the D.C. Circuit panel decision concluding but not analyzing why it would be a federally run exchange. And then we have some light blue states, which are federally supported state-based exchanges. Oregon, you may recall, had an extremely difficult or horrific rollout of the Affordable Care Act exchange enrollment in 2014. And so they have moved their exchange to healthcare.gov. It's still wholly state-run, but using federal infrastructure in order to conduct enrollment activities and assessing individuals for eligibility for subsidies. Nevada, which had a state-run exchange in 2014, is also moving this route to use that healthcare.gov infrastructure. And New Mexico, which operated a federally facilitated exchange in 2014, is now moving to a state-run exchange that is federally supported, like in Nevada and Oregon. And then the remaining dark blue states are federally facilitated. So when if the Supreme Court concludes that an exchange established by a state doesn't include the federally facilitated exchanges, the remaining question would be, well, then where do we draw the line between these pure state-run exchanges, like in California and Kentucky, and the pure federally facilitated exchanges like Texas and Florida? So how does Illinois fit in? How do Nevada, New Mexico, and Oregon fit in? And are there other models for exchanges that might fall between the federally supported state-based exchanges and the partnership exchanges, giving states more flexibility to delegate activities to the feds? As I already discussed, West Virginia involves a partnership marketplace, and the D.C. Circuit Panel decision concluded in a footnote that that was not a state-run exchange. Interestingly, West Virginia is one of many states that actually has the legal infrastructure to establish a state exchange, but West Virginia ultimately chose not to implement it because of financial concerns. A number of states moved along towards establishment of a state-run exchange, like Pennsylvania and Mississippi. And so in the context of an adverse decision from the Supreme Court, there are a number of these red states on our exchange map that might convert to an alternative model for their exchange in order to fit it within the definition of an exchange established by the state, however the Supreme Court defines that, so that they can tap into those subsidies for their residents. It's worth noting that if we have a decision from the Supreme Court in favor of the challengers, the elimination of the subsidies in these states would have a significant impact on the individual mandate. Fewer households would be subject to the individual mandate absent the IRS rule, or if the IRS rule is overturned. And that's because there's an affordability exemption to the individual mandate. The individual mandate is only applicable if coverage is unaffordable, meaning premiums on the cheapest plan would exceed 8% of the household income. And without these subsidies render coverage affordable in most states, so without these subsidies, coverage would then become unaffordable for most of the impacted individuals, and they wouldn't be subject to the individual mandate. And this is actually the theory that allowed for the courts to recognize standing for the challengers. The challengers in both Halbig versus Burwell and King versus Burwell are individuals who would not be subject to the individual mandate but for the premium assistance tax credit, and therefore argue that they are personally harmed by the IRS rule extending that tax credit in their state because they are now subject to that individual mandate. In addition, there would also be a likelihood that HHS would extend its hardship exemption under the individual mandate to individuals that live in states with federally facilitated exchanges. On the employer side, a reversal would also constrict the employer mandate. The employer mandate is only applicable to large employers where the employer doesn't offer adequate coverage, an employee enrolls in subsidized coverage on the exchange. So absent the availability of subsidized coverage, employers in states with federally run exchanges would not be have exposure to that employer mandate. So, moving to Keith, who will briefly discuss how an adverse decision in King might affect legislation in 2015 and beyond.
So this is potentially one of the most, and I say potentially because it depends on obviously how the court rules, but potentially one of the most significant events on the legislative horizon, for the simple reason that the structure that's left, as Katrina described, were the court to rule adversely in the King case, adversely to the administration in the King case, could leave you with a situation not unlike you had in many cases before health reform was enacted, only potentially even more messy. It's unlikely that the court would strike down many, for example, of the rating rules and the various things in the Act which were predicated really on having a structure of subsidies in place, so guaranteeing the issue, 3-to-1 rating bans, and all these kinds of rules, which would make it extremely difficult for markets to function in the absence of the complete regime of subsidies and the like. So that creates a situation where I think you're going to want to see Congress act and be for something, and certainly the administration in the same case, looking to see what it can do. So the first question, as Katrina went through so nicely, is where might this line be drawn, and which states are left out, which will have extraordinary impact on the congressional landscape. The administration's ability to exercise flexibility in defining what a state exchange is will depend heavily on how the court rules. But this need to be for something is likely to drive the next set of legislation around this, and they may not know until the middle of the session. So they may be off and running down a legislative course only to get a major curveball, and believe that they are planning for these kinds of contingencies as we speak. It's also important to realize that some critical things like the Children's Health Insurance Program, funding drops there from about $21 billion to about $5 billion, $6 billion. CHCs, which community health centers, which get about an extra several $1 billion under the Affordable Care Act, all those things vanish and need to be reauthorized for 2016. So watch for those things to play a role sort of as part of any kind of fallback plan. Even more significantly, in a lot of ways, the key thing about a lot of federal legislation these days has become what it costs. We operate under a regime, both political and statutory, that says you're supposed to pay for costs as you go along, the so-called pay-go rules. Once the Supreme Court acts, that's effectively a change in law. Not effectively, it is a change in law. And the agencies that actually estimate costs of law, most notably the Congressional Budget Office, will pretty immediately take that into account in deciding what to do about future legislation. So let's just say the court rules adversely, and a bill comes along the next day to reinstate the law that was there before the Supreme Court action. Well, that would cost a fair amount of money. And so that becomes a major part of all this congressional legislative consideration. And of course, in the various states, the sort of baseline for political pressure, if you will, as to whether they define themselves as a state exchange has now changed. Before, a governor could look back and sort of say, well, I just won't do anything, and then the Fed step in as a federal fallback exchange. That's no longer the case. So now the heat is turned on them, and much as you've seen in the case of Medicaid expansion, where when the Supreme Court ruled that was, in essence, optional for the states, it set in motion a whole new set of dynamics in the states between governors and legislatures. But you could see a similar sort of thing spinning out around the exchanges as well. Now you have both exchanges and Medicaid potentially together. But that's not the only case that's out there. There's another one that was filed not too long ago that Katrina will cover.
Right, thank you. Yeah, so as I mentioned before, shortly after President Obama's announcement concerning immigration, the United States House of Representatives filed a suit challenging two aspects of the executive's implementation of the Affordable Care Act. First, the IRS's non-enforcement of the employer mandate in 2014. The ACA specifies that the mandate was to take effect beginning after December 31, 2013. And so the House is arguing in this suit that the executive did not have discretion to decline to enforce the employer mandate in 2014. In addition, this suit challenges the administration's authority to issue cost-sharing reduction payments at all. The ACA allegedly lacks the necessary appropriations in order for these cost-sharing reduction payments to be paid out to plans for eligible individuals. As I mentioned before, the cost-sharing reduction payments are payments made to plans to give to offset the cost of giving more favorable cost-sharing packages to eligible individuals up to 250% of the federal poverty level that enroll in a silver plan. In short, if you, depending on your income level, if you enroll in a silver plan and receive cost-sharing reductions, you might get something that's a Silver Plus plan, so at a 73% actuarial value rather than a 70% actuarial value. Or you might get something more akin to a Gold or a Platinum plan. So you get to pay for the lower cost plan and receive premium assistance tax credits to offset those premiums, but enjoy the lower deductibles, lower co-payments, and so forth of a more expensive plan. Far fewer people receive cost-sharing reduction payments as compared to premium tax credits because of the lower threshold for eligibility at 250% of the federal poverty level rather than 400% of the federal poverty level. But for individuals that are between the Medicaid eligibility level and that 250%, this is an important way of being able to actually access health care using a plan, accessing health care beyond preventive coverage without it being financially debilitating. And it's also important on the provider side to be able to serve individuals that don't have cost sharing that's wholly disproportionate to their economic means. So, not having a $5,000 deductible and a $6,000 or $6,600 out-of-pocket maximum. Now, the suit that was filed it was filed by the U.S. House of Representatives. They got authority to file the challenge back in June along a largely party line vote, so it's sometimes referred to as the House Republican suit. And the fundamental question as House versus Burwell proceeds is going to be standing. So does Congress, does the House of Representatives have standing to challenge the administration's actions under the ACA? And just by way of general background, standing is a threshold procedural question that examines whether a plaintiff actually has a legal right to a judicial determination of the issues in a case. And the court standing doctrine comes from two sources. The one is constitutional requirements, and the other are prudential considerations. And as a general matter, in most cases, we require that a plaintiff, in order to have standing, must allege a personal injury that's fairly traceable to alleged unlawful conduct by the defendant and is likely to be redressed by the requested relief. Now here, it's that there is not an individual plaintiff that is arguing that they're being personally harmed as a citizen by reason of the cost-sharing reduction payments. It's hard to conceive of a employer or a potential beneficiary or other group that might be adversely impacted by the cost-sharing reduction payments. So instead of using individual plaintiffs, this challenge is brought by the U.S. House of Representatives. And so the standing question will turn on whether there is congressional standing. Now, suits by individual legislators are one of the few things that the Supreme Court has explicitly addressed. In Raines versus Byrd, the court significantly limited the standing of individual legislators to challenge executive action. But this is a suit by an entire House of Congress. And here there are more open questions about whether it's permissible. We don't have Supreme Court precedent really on congressional standing and the reaches of congressional standing. But the lower courts, particularly the D.C. Circuit and D.C. District Court, have addressed congressional standing, but most of these cases have arisen in the subpoena enforcement context, which is fairly different than what's at issue here. And it's unclear if the D.C. courts would distinguish their prior jurisprudence based on the different contexts. More than likely, the court will demand that that the House show a concrete and particular institutional injury, perhaps an injury that amounts to vote nullification. Now, here that might be difficult because Congress ordered the executive to issue cost share and reduction payments, but Congress also didn't include adequate appropriation language in the ACA. And so that, the institutional injury is less clear than when Congress speaks clearly and says, to not issue cost sharing reduction payments or to do something, and the executive goes contrary to that instruction. So we're expecting that the briefing in House versus Burwell as it proceeds will largely focus on standing, and that will be the prime issue that the courts will be addressing as this case proceeds. And moving back to Keith and Marty.
Slide 22. So one of the words you're likely to hear a lot about in the coming months is the budget resolution and reconciliation processes. These were established by the Congressional Budget Control and Empowerment Act of 1974, and they were one of the most, at least as we speak of, senatorial changes, one of the most important and critical. The main reason for which is this is a process that allows the Senate, under special rules and special procedures, to pass bills with a simple majority vote. It doesn't entirely negate the value of a filibuster, but it allows an enormous amount of control. And Marty talked about Senator Enzi and the Budget Committee. This becomes an extremely important process, particularly by which the Senate can manage under some set of rules, not as tightly as the House of Representatives can, but can move very, very large pieces of legislation through this process. This begins with a budget resolution. You can think of this sort of like a train as it starts off and it gets going, and it gradually builds up a head of steam, and it culminates in a fast-moving, very heavy and large vehicle. Well, much is true of the budget resolution and reconciliation process. First, Congress establishes an architecture for the bill, which basically is which committee will have to produce how much in terms of savings and the like, and it issues specific instructions for how that is to occur, and then it moves forward with that. If the Congress were to move the ACA issues under this umbrella, particularly likely, particularly if it was, say, a repeal on some issue that's likely to meet with a veto, could waste an enormous amount of congressional time, only to result in something at the very end that could not be enacted. However, for entitlement reform issues like Medicaid and Medicare changes, this is a critical vehicle, but it has limits. Slide 23, please. I won't go through all the details on this, but on slide 23, you'll see a little thing known as the Byrd Rule. The reconciliation is extraordinarily powerful and extremely important. However, it is also limited in scope to some degree. And this basically, if you skip down, it says, any senator can, upon a point of order being made, right, any part of said title or provision that contains material extraneous to the instructions to said committee. Remember, the instructions are about producing budgetary savings. So what this means is that an individual member can strike from a reconciliation bill anything that does not really have a direct and primary purpose of having a budgetary impact. More correctly, they can strike anything that's extraneous to that budgetary impact. That means, for example, a simple rule that doesn't have a primary purpose of saving money or impacting the budget can be knocked out. This was a huge issue in the passage of the Affordable Care Act, and it's one of the reasons why we have a lot of language problems is because many of those changes could not be effected through reconciliation. This could get into issues around private market rules and many of the things in the Affordable Care Act that one might want to reach to in the Congress, that the Congress might want to reach to, but might not be able to. It turns out one of the people who is most important in determining what can go in and out of a reconciliation bill is someone who is relatively unknown, known as the parliamentarian of the Senate. Apart from that process, slide 24, please. One of the most difficult bills in Congress is always the debt ceiling bill, and it comes up again, it expires in mid-March, but the Department of Treasury has a number of techniques at its disposal known as extraordinary measures, which have become virtually normal in recent years. It might stretch that into May, maybe even later. So a big question will be here is, because that is a difficult vote and a challenge for members, does this get married up with a budget resolution, with reconciliation, or what? Slide 25, please.
So picking up here and trying to drive toward home, let's just focus briefly on some of the pending health care legislation that we should see in the next Congress. Obviously, one of the first things out of the box will be the annual extenders. Now, currently there are about 20 provisions, about half of them Medicare, the other half Medicaid and other provisions, that will come up for a reauthorization or an extension by mid-March. Notable among those is the sustainable growth rate, or DocFix, the famous SGR. I'll talk about that in just a second. The other issue that we'll likely see, although it's pretty much acknowledged that they won't succeed, will be further efforts, further votes on so-called repeal and replace. That is, Republicans in the House and Senate have made it pretty clear, and their leaders have acknowledged they'll run those issues out there, but they know at the end of the day they would likely face a veto. Now, there may be some piecemeal efforts on which there might be some amount of bipartisan support and maybe even some agreement by the administration. For example, around device tax, and those issues, some of those issues could end up, if there is bipartisan agreement, on a reconciliation bill. Others, however, wouldn't meet the Byrd Rule test and would have to go on their own. So mid-March, there'll be issues of the extenders, of SGR, and potentially some measures to make some changes in the Affordable Care Act. Obviously also the reauthorization of the CHIP program, for which there's a good bit of bipartisan support, but was not able to be reauthorized in this past Congress. Now, just briefly on SGR, the legislation has advanced substantially over the course of the last year. All three committees of jurisdiction have taken it up. House and Senate committees were negotiating on the side, but it had to be shelved for lack of time, and most importantly, lack of consensus on how to pay for it. The policy goals in the pending bill will probably be similar in the next Congress. It will have to be reintroduced as new legislation in a new Congress, but the big question mark is still how to come up with $120 to $140 billion to pay for it. And that could mean a lot of provider cuts. It could even mean some potential adjustments in beneficiary out-of-pockets. But that legislation will certainly have a head of steam behind it and could be the vehicle that pulls through other health care legislation that wouldn't survive on a reconciliation bill. And so I think with that, we'll stop and ask our moderator perhaps to step in.
Hi, thank you so much. What a wonderful presentation. We know that we have hit the hour mark. However, we will go through the questions. We have just a few, and if anyone has a question, we encourage you to send it in via the Q&A bar through GoToWebinar. And our first question is, do you have any thoughts on the petition filed by the state of Oklahoma to have their case heard along with King in front of the Supreme Court and any inkling on what might end up happening with that?
You know, I haven't, looked too closely at that issue. The distinction between the Oklahoma case and the King case actually turns on the standing of the challengers. Oklahoma is in a bit of a different situation. There is actually, on slightly shakier ground than in King. So there may be a reason to decline to combine the cases so that the issues do not get as muddled or confused. Hearing King would allow the court to focus on the one issue of significant nationwide impact. But that's just me, speculating from over here, not and far removed from the justices' chambers.
Thank you. Our next question is about the SGR, and the question is, what are the possible ways that Congress will try to pay for SGR reform, which have the best chances of obtaining a consensus?
There's already a long list of potential pay-fors, as they're called. The committees of jurisdiction have posted those in the past without endorsing any of them. There are provisions that are under the label of site neutrality. That is to say, once a patient is discharged from a hospital, should they receive care in an inpatient rehabilitation facility, in a skilled nursing facility, through home health. What's going on this one is MedPAC, Medicare Payment Advisory Committee, as well as the committees, have all raised questions as to whether or not we should be paying differential amounts, and if so, how much, across those settings. Obviously, payments to hospitals are always potentially vulnerable. But there's also been some interest, particularly among Republicans in the House and Senate, and a few Democrats, to revisiting the amount that beneficiaries pay. For example, you could combine the deductibles across Parts A and B into a single deductible and perhaps achieve some savings from that at the same time. There are always provisions that CMS could undertake through regulation, which Congress might say, rather than you doing it through regulation, we'll do it through a piece of legislation and get credit for it. So there's a long list. Now, the second part of your question as to what's more feasible or possible, I think really remains to be seen. The congressional leaders were not willing to have their members vote in this past year on any of these offsets since they were worried about the election. That worry is not going to go away. Senator McConnell, in particular in the Senate, is going to confront a situation in which in 2 years, 24, 25 of his members will be up for re-election. So if there's going to be any action on SGR and if it is going to be paid for, it probably has to happen within the first several months of the next Congress, unless they decide just to waive the Budget Act and not pay for it.
Thank you. We have another question. Will any of the topics that we discussed today affect implementation of ICD-10 again?
Well, ICD-10 is a sort of continuing perils of Pauline for as long as I can remember. The constituencies that have been opposed to its implementation, I don't think are going away. We could very well see another attempt to push back that deadline attached to any one of the vehicles that might be moving through the Congress. CMS, in the meantime, as you probably know, is holding their webinars and other training activities and operating under the assumption that ICD-10 will be implemented next fall. But I've stopped predicting on this one. I've been wrong too many times.
Thank you. I think that we've reached the end of our question queue, so I'd like to just thank all of our presenters today for your time. And again, to everyone listening, please watch your inboxes for the emails with information about CEUs and a survey. Thank you.